And so we welcome our panelists. We've got, well, we'll let everybody introduce themselves, but I just want to say quickly, I'm Juanita, and I'm with the Spina Bifida Association. And so, Terry, you can go ahead.
I'm Tara Harris. I am an OB-GYN working out of Baylor College of Medicine in Houston, Texas, and I work with women with special needs, disabilities, spina bifida, all the things.
And Sammy.
Sammy, I think
I'm Samantha Perez, or Sammy. I'm an adult with spina bifida, and I'm also on the SBA Adult Advisory Council.
Karen.
Hey, I'm Karen Kushner. I'm an adult with spina bifida, and I am a member of the Adult Advisory Council.
Kristen.
Hi everyone, I'm Kristen. I'm an adult with spina bifida. I'm on the SBA Adult Advisory Council, and I'm a board member for the Spina Bifida Association of Greater New England. And I'm excited to be here.
And Libby.
Hi, I'm Libby Powers. I am an adult with spina bifida, and I am also on the SBA Adult Advisory Council, the Research Council, and a variety of other panels and boards for the SBA.
She does a lot.
Next slide. Let's.
Oh wait, did we do everybody?
Oh,
I'm sorry.
Everybody have the list.
Did we do
Yeah, we
Kristen?
did everybody.
Oh, we did. I'm so sorry. Okay, sorry.
Thanks for coming, guys. So we're going to have you, if you have questions, comments, concerns, you can always do the chat box. Types in your question, your comment, your concerns. This is not going to be a fully comprehensive talk because we've already established that would probably take me 2 days. I could do like 15 talks. So we're going to do this as a conversation, and we're going to bring up some topics, but just let us know if you want to hear more about something else, and we'd be happy to do it. Okay, so let's talk about patients with spina bifida and what are the barriers. So one of the studies, and you guys know this, you don't need studies to tell you this, you know this, you live it. Women with spina bifida and other physical differences are more likely than the general population to have experienced difficulties with routine reproductive health maintenance and screening. They are less likely to receive pelvic exams, pap smears, and information regarding sexual and reproductive health. That's certainly true. As a gynecologist who specializes in this population, I can tell you that the vast majority of my patients, I'm the first gynecologist they ever met. For various reasons that is not necessarily by their choice. And so I believe the data because I feel like I live the data. I'm sure you guys do too. I want to do a quick overview of anatomy because I find that a lot of my patients, and certainly not just women with spina bifida, a lot of patients don't really understand all the parts involved. So one of the things that I like to do during my visits with patients is say, do you understand your anatomy? Let's go over it, because understanding what's going on in your body is really empowering and actually allows you to, feel like you know what you are talking about in some very clinical terms. So let's just kind of review it. So this is just a nice drawing. So in the female reproductive system on the inside, we have the uterus, and we have ovaries and fallopian tubes, the cervix and the vagina. There are so this is the standard view. Not all women's fallopian tubes and ovaries look like this, and that is okay. We will find sometimes differences about people's anatomy. Like maybe their uterus doesn't look like this. Maybe it's like only half of what this picture is, or something like that. But it's important to note, this is kind of what we're talking about in some general terms. Okay. Basically, when it comes to periods, what happens is every month the ovaries are making hormones in response to hormones that are controlled by the brain. And what that does is it signals the ovaries to ovulate. The egg goes down the fallopian tubes and into the uterus. If it's met with sperm at the appropriate time, then it can implant and get pregnant. And if not, then the endometrium just kind of sits there, the lining of the uterus, and then it will get a withdrawal of hormones that will cause it to shed. And then that blood comes through the cervix and out through the vagina. And that's kind of how periods work. Any questions about that this far?
Just a quickie thing just from me, Tara. We can hear you, but sometimes it fades out just a smidge. So I'm wondering if maybe you want to get just a little bit closer.
Oh yes, let's show all the pores and wrinkles. Let's do it. Okay, so, whoo, Lord, high def. Can I get that Susan Lucci filter maybe? Anyway, okay. Any questions? Okay. So what's a wellwoman visit? You guys have probably heard of what of a wellwoman visit is. You're supposed to be your annual visit, or people like to just call it their pap smear. It's not actually just their pap smear, but that's what people tend to refer it to as I got to go for my annual, I got to go for my well check. So what I'm giving you is in an ideal world, this is all the stuff that would happen in a wellwoman visit. This is the stuff that we get from ACOG. They're the American College of Obstetricians and Gynecologists. They've written a whole thing about what should be part of wellwoman care from a gynecologic standpoint. This stuff all takes time. So I would not at all be surprised if you guys have gone to your visits and not gotten some of this stuff. But this is what is recommended to happen in an ideal wellwoman visit. So taking a comprehensive history, past medical, past surgical, medicines, allergies, family history, all of those things. Doing age-appropriate screening, because depending on how old a woman is, we may need to do certain screenings versus others. Like for women who have a higher risk or at the age of, menopause, we're looking for things like postmenopausal bleeding or worrying about fractures and falls and things like that. If you're younger, we're talking about certain vaccines. If you're of childbearing age, the stuff that we talk about whenever we're thinking about maybe getting pregnant, all of those things. And there are some guidelines based on age. Screening for high risk behaviors. Okay, what's a high risk behavior? Well, smoking, alcohol abuse, drug use, sexual partners. Do we engage in some risky sexual behaviors? Like, are we being safe? Like, are we using condoms if we can? Protecting ourselves, things like that. Are there guns in the house? Are they locked up? Do people wear seatbelts? There's lots of stuff that can be part of high risk behaviors. Counseling on maintaining a healthy lifestyle, diet, exercise, sleep. Do you drink water? Simple things, do you do these things? What's your stress level like? How are your emotions? Screen for depression, anxiety. Do you need referrals for certain things? How to minimize high-risk behaviors. And we've highlighted for immunizations HPV, specifically because I found that many of my women, you guys are familiar, I'm sure, with the HPV vaccine. It's the vaccine that's against the HPV virus. The HPV virus is a virus that is known to cause a couple of different cancers. But from a gynecologic standpoint, we worry specifically about cervical or vulvar cancers, but it can also be involved in rectal, oral, throat, things like that. And so have you been offered the HPV vaccine? Or maybe you were offered it when you were younger and your parents don't feel comfortable with it, but now you are an adult. Do you want to make that decision for yourself? Things like that. So certainly that should be part of the wellwoman visit. So ideally, like I said, I review anatomy. I'm spoiled, y'all, because when it comes to my visits, I have a lot longer than most people. They've allowed that. I work for an academic institution, and they're very supportive of what I do and the patients that I work with. So they allow me more time. A general gynecologist might only have 15 minutes. I mean, can you imagine how long some of this takes? So this is not to make anybody look bad or anything like that. I get time that other people simply do not have. But this is what I do. I do review anatomy. I do review menstrual cycles like I did here. Talk about pelvic health and prolapse screening. Sexual practices or concerns, STD testing, contraceptive needs. You know, are you taking your folic acid? I mean, there's lots of stuff that we go through as part of a well visit and try to address. Sometimes my well visits end up being problem visits, but that's okay. Yeah. And then let's talk about internal examinations, and what I mean by that are pelvic exams or anything. Anybody want to say anything up till now? Because then we're getting into more of the nitty-gritty.
Hey Tara, are you able to turn up your volume or get closer to the mic?
I can try to get closer to the mic. How is this work? Is this better? Okay, let me see if I told you I have no idea how to do this. And so let me see.
So actually, where is the, I guess maybe the question is like, where is the mic? And
I have an idea.
and
Does this work better? Oh, good.
Oh.
Well, I just did something. I just did something.
I think
how's that
so.
now?
That sounded pretty good.
Yeah, that's a bit
I
better.
changed my
Yeah.
default speaker. Okay. Okay. Like if it happens again, somebody grab me. Okay, just stop me. Okay. Any questions about anything so far? Anything in the chat or anything?
Well, yes, we do actually we had some questions about volume. We do have some things in the chat, and actually I just want to say it sounds clearer, but now you sound more distant. I don't know if that.
Oh my Lord. Okay. How's that?
Okay, I think that's going to be fine.
Talk very loud for me. How is that?
I feel like that's okay. I feel like that's okay. We'll just power through, and maybe because the audio is funny, maybe it's just maybe just go a little bit slower just to help the microphone catch up.
Can do. Okay. And
Okay, so sorry about that. Everything of course was fine before,
yeah,
but we
I
do
have
have
no idea why.
we do have some things on the chat.
Sure.
And someone mentioned that she just had her first pap smear a few weeks ago, and that somebody else said accessibility is the #1 reason that she's not been able to see the gynecologist. And then we also had, can you tell me if uterine fibroids are common in women with spina bifida?
Well, I can say that fibroids are common in most women. I don't think that there is a specific preponderance of fibroids in women with spina bifida, like any more than the general population. If you did, the thing that I learned when I was in medical school was that at the end of life, over 80% of women would have at least one. So not necessarily spina bifida patients specifically, just all women have a risk of fibroids. Some of them are very small and don't cause any problems, and so people don't know about them. And some of them are large or numerous and can cause problems.
Can you explain what a fibroid is for those of us who are familiar?
A fibroid is basically, we call it a tumor, but the word tumor is very scary. Okay, because the word tumor implies cancer, but it's not typically a cancerous tumor. It's a benign tumor. It's a growth of muscle cells. Like it's a fibrous growth. They're kind of hard. I'm trying to figure out how to explain it. They're like hard growths that look like little balls. And they can be in the uterus. They can be other places too, but typically when we think of fibroids, we think of them in the uterus and either in the lining, in the muscle, or growing more on the outside. And most of them are not cancer. Most of them do not cause a problem. Like I said, many women have them and have no idea because they're small and they're not causing a problem. But sometimes they can cause things like pain or bleeding. Any other questions? How's the volume now?
It's Speaking for myself, I think it sounds good.
Okay. Okay. And I'm happy that somebody got their pap smear. That's great. So let's talk about pelvic exams and pap smears. So from the ACOG standpoint, these are the ages at which we do pelvic exams or internal pelvic exams for women. Different recommending bodies might think differently, but this is where it's coming from a gynecologic standpoint. So from ages 13 to 20, we typically don't do internal pelvic exams unless we absolutely need to. There's lots of things that we can just test for with just a Q-tip. So it's not necessarily a routine thing. But if someone has a problem that we need to address, then that's different. From 21 to 39, the word they used was periodic. And then from 40 to 64, the word they used was annual. I don't know what periodic means, but I know it doesn't mean the same thing as annual. And so how often we do them in 21 to 39 really kind of depends on the patient, you know, and what's going on and what their desires are, you know, because sometimes people just want to have an exam and sometimes something's going on that we need to, and sometimes they don't, you know. And then 65 is pending medical assessment, and that gets very complicated. So this is the dreaded speculum. Okay, it's one form of a speculum. It's probably the most common thing that gynecologists think of when you use the word speculum. They come in different sizes and shapes, actually. They come in different materials. This is a metal one. You may have a plastic one. They're different. Everybody uses different things for different patients, and so it's not one size fits all. Let's just say that. Okay. So I think it's important that people know what's going into them. So I tend to show patients the speculum and say, this is what it is, just so you know. But you know, you can always ask your gynecologist, hey, can I see the speculum? You know, like, so don't be afraid to speak up. So this is kind of like that. Don't be afraid to speak up. If this is if you're going and you're having your very first pelvic exam and pap smear, please let them know. You know, like hopefully they've asked that as part of the comprehensive history. When was your last pap smear? Or if you're 21, have you ever had one? You know, like, but if they don't ask, tell them, okay, because that's important. You may need assistance transferring to the exam table, you know. So in my setup, that's pretty easy because I'm anticipating that for a lot of patients. Some doctors don't have setups that can accommodate that. And when I mean setups, really what we're talking about is tables that will adjust. You know, they're motorized, and so they're not in every exam room, even in my clinic. And so if you need that, I think it's really appropriate to ask when you're making the appointment. You know, like, do you have that? You know, this is what I have. Can you, this is what I need. Can you accommodate that? In the age of COVID, my hospital currently has a policy of no visitors. And so for some of my patients, that's a really big deal. You know, it's in the clinic, you know, it's not no visitors in the hospital, but no visitors in the clinic. And so I've gotten permission to have people come, whether it's caregivers or, you know, family or whatever, in order to facilitate that if needed. So if you need that, speak up. Don't feel bad, but, you know, tell them when you make the appointment, hey, I need these things. And then that's what we're saying about ask them if the table moves up and down, because that's kind of the setup that most women need. Most women are actually fairly good at transferring. You know, they tell me how to do it. When I have a patient, I'll say, do you need help? They're like, no, I got this. You know, like, okay, you know, just tell me what I can do to help you. So don't be afraid to speak up. Does anybody want to talk about any of their experiences?
Yeah, I think when we were speaking earlier, a couple of the panelists had talked about just sort of, I think one of the things was like, don't just automatically get someone to transfer me. Ask me first, ask me for permission first, because I might be able to, I might want to try myself first before, you got help. What were some of the other things that you'd mentioned? I think you also talked about some, like maybe there's some alternate positions that.
Oh, yeah. Okay. So I think that's the next slide. Is it? Oh, cool. Okay, so typically when people come in for their pap smear or pelvic exam, this is what we're talking about. So to review the components of a pelvic exam, basically we're supposed to look on the outside of the vagina. We're looking at the skin. We're looking to make sure there's no skin breakdown or moles or lesions or anything that needs to be tracked. That is awkward. It doesn't hurt, but it's awkward, right? Like, have somebody look it down there, and then the pap smear part, or the first part of the internal pelvic, is a speculum exam, where we put the speculum, we have the patient in the stirrups typically, and this is the standard way, but there's lots of ways to do this. And then put the speculum in the vagina, looking at the walls of the vagina and the cervix, and then taking the pap smear if needed. And we've got some pictures of pap smear brushes. And then taking the speculum out, and just like in the picture here, putting fingers inside the vagina. And also what's not in the picture is putting your other hand on top of the uterus on the abdomen to try to feel the uterus and the ovaries, and to make sure we don't feel any big masses or things that shouldn't be there, or that things don't feel stuck, because sometimes that can be indicative of a problem. Not every pelvic exam necessarily involves all components. It depends on what the needs are, but this is kind of what we think of. Now, for the alternate positions, I find the alternate positions very helpful. So you don't actually have to have patients in stirrups. And a lot of my patients can't use stirrups. So we can do things like hold their legs back for them, like not in stirrups, but kind of like in a chair position, where we're holding the legs. You can also be on your side, kind of in that position, that also gives access. And there's lots of other ways to do this. And so I couldn't find any appropriate illustrations to show us this. But there are ways, and a frog leg, having, legs just out to the side, that's also, like, flat on the table, that's also acceptable. Like, there's lots of different ways, is what I'm saying. So if you aren't somebody that can use the stirrups, that's okay. Like, don't think that that means you can't have this done, or that your pelvic exam is less valid. Like, this is a doable thing. Okay.
Yeah, just quickly, just somebody mentioned, well, there's been a few comments, but somebody mentioned about how having an accessible table is or should be part of the Americans with Disabilities Act. But I guess just like but the reality is just that not all facilities have them. Is that right?
Like I said, I got spoiled. I haven't ever worked in a clinic that didn't, because I work in an academic institution. I can't speak, unfortunately, to what the ADA actually covers as far as exam tables, but I actually think that you are correct, and they should.
Yeah, I guess I wonder if it's like why wouldn't
Why wouldn't they?
Yeah, I mean, I have that at my dentist, you know, to clean.
I do not know the
I wonder if
answer.
it's that they're more expensive or newer, you
I'm
know, a
sure-
lot of like it's,
I'm
yeah.
sure they're more expensive. You know, like, and I do know that sometimes they break. We run that, but what the like cost differential is, I don't know. But I agree with you. And it's not just for my patients who need to transfer, but in general, it just makes everybody much more comfortable. I think.
Yeah, I think we're seeing here that people either are calling around and cannot find a single GYN with a table that lowers. I mean, the anxiety that gives people, they're just not going to go to a GYN. Imagine that. You know, it's pretty sad, but there are some out there, and hopefully it will get better.
And, you know, and in the meantime, though, I think, you know, the point too is, you know, like, well, that's not correct. It's not a good thing. But at the same time, it is empowering to know that your providers should be aware of other positions that they could do. You know, it's not the ideal, but there is a way, and this is not, it should not hold you back from getting this very important exam.
Right.
And
A lot of people, I'm going to just dovetail and add something. I think for exam rooms to have adjustable tables, I think it's also a space issue of clinical exam rooms being closet size rooms that can fit a desk, a computer, a exam table that's smaller and flat is more seen because of space. Since patient exam rooms tend to be on the smaller size.
one thing that people might consider asking if they're calling is, do they have a procedure room with an adjustable table? Because a lot of our procedures, actually, you know, things like biopsies and whatnot are actually super, it's one of the reasons why I love adjustable tables in general, just because they actually make everything easier. But the front desk staff may not be thinking of something like that. You know, like, so if they have perhaps a procedure room with an adjustable table might be another question to ask. Or seeing if you can talk to one of the nurses and asking, you know, more questions and say, can I be accommodated? Again, don't be afraid to speak up. And if you don't like the answer you got first time, ask somebody else. Anything else in the chat that we need to talk about?
There are a few comments, really, really good comments, and maybe we can get to them afterwards. I just want to make sure that we cover all the information.
Okay, this is basically here just to talk about what a pap smear itself is. The pap smear itself is just taking one of these little brushes and putting it against the cervix and getting some cells, and that's what goes to the pathologist. And that's looking for abnormalities in the cells that could be a precursor to cervical cancer. You can also run an HPV test now on pap smear samples to see whether or not the HPV virus is present. So things that you should be able to do and feel empowered to do. If your doctor is not giving you the feedback or the step-by-step of what they are doing and what you can expect, then tell them, say, ask for it, demand it. You should be able to get that. That is, they aren't doing you a favor, okay? Like this is their job, you know, and so you should ask your doctor if you want to know. I do run into patients who don't want me to say anything. I have a very hard time with that because I want to narrate the steps. I want to say, I'm now doing this, I'm doing this, I'm doing this. And sometimes they tell me to shut up. And that's fun, you know, but ask them to walk you through, what are they gonna do? What can you expect? What sensations are usual? What part might be uncomfortable or even potentially hurt? If something hurts, say to them, if this hurts, and I tell you, will you stop? You know, like, and if they say no, they're not going to stop, you need to get out of that office. Okay, like that, and report them. Yeah, like, because there's very few times in my life that I can't stop what I'm doing, you know, like, because something hurts somebody. So the things that I always tell my patients is, none of this is comfortable. You know, like, it's not. I'm not gonna lie. You know, like, I don't like getting mine done either. You know, like, but I mean, I sit there and hold my phone and clutch it, you know, and just keep my eyes shut. And it's one of my friends who does mine, because we're all, you know, guys are all friends. And so if I feel that way, I imagine everybody kind of feels that way. So what I like to tell my patients is, none of this is comfortable. I don't expect it to be comfortable, and it's all weird, but it shouldn't hurt. You know, like, if something hurts, I need you to tell me. You know, like, so, you know, they should go slowly. They should ask, you know, is this okay? Are you doing okay? You know, and that's what you should be asking. These are the conversations that you should feel like you should have. You are not being a demanding patient or a, you know, like a mean patient. You're being a human. You know, like, this should be the standard, you know. So, and I say that as someone who does this a lot, you know, this should be what everybody gets. And the last point here, at some point, it may not be possible to stop certain procedures. That is true. That's not a pelvic exam. Pelvic exam should be able, pap smear, you should be able to stop, you know, like, but if I'm placing an IUD or something like that, there may be a point where I have to do what I'm doing, or else you're going to have like half an IUD hanging out. And so, but that should also be clear. If you're getting a procedure like that, or say a biopsy or something, you should be clear at what point, is there a point that you can't stop? You know, like, but that shouldn't be part of a pap smear. I think that was, and these are just pap smear brushes, and this is the cervix with the pap smear brush going in. This is a spatula. These are all different kinds, and I think this is one of those things that we wanted to, well, to call ahead, like we said, if you can't stand, oh, we're talking about mammograms now, sorry. Let's talk, does anybody have anything else to say from the panel, or anything else about their experiences or problems that they have had that they want to bring up?
I think it's just really important to mention that, which you sort of mentioned earlier about potentially having someone with you. And that's not just for transferring, it is for your making sure your voice is heard and having someone have your back, and for consent, what you just mentioned. So having a safe word or something, and if they hear it, making sure that the person doing the exam listens. You know, hopefully that's never an issue, but you just never know.
Yeah. Do you feel that maybe, you know, in some cases, maybe because, you know, providers maybe not having a full understanding of the sensations that you might have, maybe don't realize that maybe you do have, you know, I don't know exactly what I'm trying to say, but do you feel like maybe that's something that you really need to remind providers, that even though you do have spina bifida and can't feel some things, there are things you can feel, and, you know, they need to be careful?
I think that there is a lack of understanding sometimes of what a specific spina bifida patient, because of course it all is determined by the level of the lesion. But, and yes, OBGYNs, and that's another thing that, you know, is probably, I don't think is on any of our slides, but, you know, OBGYNs learned about spina bifida in medical school. Like they didn't study it, like your internal medicine doctors or some of your other ones, because it's just not part of it. And so they may be like a little like having to go Google, like to be like, okay, what do I need to know about this, before, they may not have any experience. I didn't have any experience at first. I never did this in residency. Ellen Premier had to teach me everything, and so, so your provider may not have that level of knowledge. But the thing is with spina bifida is they should not be assuming anything about lack of sensation. They should be assuming that you feel everything the same way everybody else does. And they should treat you in the same way. If it happens to be less uncomfortable for you because of because of the level of your lesion, fantastic. But that's not, but nothing that we do should be different. Does that make sense?
Yeah, and it sounds to me like it's really key to have like those conversations like before the exam, just so that everybody's sort of on the same page.
Okay, let's talk about mammograms. So one of the issues, so mammograms are for screening purposes recommended by many recommended bodies to start at age 40 for a general population. For people who have certain risk factors, family history of cancer or certain genetic issues, it may start much more than that. But for a general average risk population, start, oh, what did I just do? Oh, good Lord.
Whoa.
I don't know what I did.
Preview. Okay, there you go.
Spoiler alert. And so starting at age 40 is typically what is recommended, and annually to every 2 years. The problem that we have with some mammogram stuff is we are unclear as to whether or not there are machines available that if people can't stand or stand long enough without balance. Because the vast majority, if not all, mammogram machines are meant for people who are able to stand for at least some period of time with little assistance. And the reason I say it's unclear is because I have been told by our mammogram people that those machines don't exist. I've heard from other places that they might, but have you ever tried to Google that? Because I can't Google it. I don't even know how. I'm not putting in the right stuff. So if anybody comes across a machine or a facility that can do it with a patient seated, will somebody please send me an email? Yeah, because I would love to know that. So that I can ask our people to go buy one of those things, So, ask them that, are there options? And if your body is not able to turn in certain ways, you need to tell the tech that, and you may have to explain about, curvature or scoliosis and work with them. Do any of you guys have experience with mammograms going badly?
Oh, I can take that one.
Please.
Yes. And the place that I go to does have a machine that you can have it done in a wheelchair. So
Can you?
I can email you that actually. But the thing is that, even though I can stand, I can't stand for long periods of time. And a lot of times they'll say, put your arm up here and twist your body this way. And with a curvature, I can't do that. And then they're, cranking down the machine to kind of flatten everything out. And then they're pinching, the side skin and you're screaming at them. And, even though I have been graced to have the same tech many, many times, I'm just one patient in a day. And once a year. So they don't always remember. So I just have to say, I'm sorry, my body doesn't turn that way. I can't, bend that way. I can't hold myself up for very long. So if we're going to do this, tell me where you want me so that then I can just kind of get up, position myself. You can, move things around. So that helps. But, mammograms for me, ever since I was in my 30s, I've always gotten called back for an ultrasound. I've always had to have, biopsies because of dense breast tissue is what they would say. So I don't know if there's anything called a normal screening mammogram in my life. I hope there is in everyone else's. And I started having mammograms at 30, and I know that now it's 40, but I would hope that, if you want one, you can get one, is what I understand, if you ask for it. So.
Wondering, because you mentioned that you've got, what is it that they asked you to do instead? I've just blanked on the name of the procedure. Instead of the mammogram, because it wasn't.
You mean the ultrasound?
I'm sorry.
Ultrasound.
Yes. Right. So wondering, what's the reason that they don't just go ahead and do an ultrasound to begin with?
Well, Tara can probably take this better, but for me, it's, they do the screening mammogram, they see something on the mammogram, and they, usually when somebody's just previewing it, they'll read it within a couple days, at least here in New Mexico, they will. And then I'll just get, they'll just tell me, we just want to take another look. We just want to be safe. Now, I don't know how they handle it where Tara is, so she can, give that information.
It depends on the facility. Our facility tends to have the radiologist read it immediately. And that way, if there is a suspicion, they do the additional imaging then, or they arrange for it right then. But I can't say that happens every single time. And I don't know I know that doesn't happen necessarily in the other facilities. To answer your question, why, so basically mammograms is an x-ray, basically, and ultrasound, and the other breast imaging that we use sometimes is MRI. And they all show things a little bit differently. And so some things, so one of the questions that one of my patients asked me when we found out that, we didn't have any facilities for her, was she said, well, why can't I just get an ultrasound? And the problem is that ultrasound doesn't screen for breast cancer like that, and you're looking for different densities of material, like you're seeing things in a totally different way. And so it doesn't screen, it's good for evaluating a mass or an area that you're looking at specifically because you found something, but it's not a good screening. MRI could be a screening, and there are some women who get screening MRIs, again, because of breast cancer history or other things. The problem is the insurance companies don't want to pay that because it's a lot more expensive. So we tried to get, for my one patient, we tried to get her insurance company to cover a screening MRI, and of course they refused. So I hope other people would have different experiences. I encourage everyone who runs into these roadblocks to get their doctors involved and make phone calls and write letters. I can't tell you at the end of the day if it's going to work, but I know that, the more people who do these things, and start demanding it, the more likely it is to happen.
Dr. Harris, is that true of ultrasounds too? Like if you were just to use an ultrasound, insurance probably,
no,
unless you find something?
No, actually the insurance would probably pay for the ultrasound because it's actually not expensive. It's just not going to work as a screening. Like it might give people a false sense of security, like, oh, well, my ultrasound was fine. Yeah, but that's not going to find stuff like that. So I think that's when I've talked to, so when I first started, I actually had the same questions. I actually went and talked to them and said, well, can we do, at least an ultrasound, because at least it's something. Because right now my patients are just getting clinical breast exams. And that's not great, you know, they explained to me why, and it made perfect sense. And that's when they suggested, well, let's try to get an MRI, but of course we couldn't get it paid. And MRI is very expensive. So it's, for the ultrasound, it's not about the cost.
We had one comment, someone said that for the mammogram, they had a special wheelchair that they offered that was the perfect height for the machine.
Oh, I'm gonna write that down. I am actually gonna write that down. Maybe I can get them to do that instead. That would be very helpful. Thank you. Good. Y'all are helping me. Unless anybody else has anything else, we'll move on.
We can move on.
Let's talk about,
Tara, we did have somebody had a question that we wanted to ask you. Can uterine fibroids be detected in a pelvic exam?
possibly. So it depends on how big they are, honestly. So small ones, no, not going to happen. If you've got, so fibroids can be so small, like 0.5 centimeter, or they can be quite large. I think the largest one I've seen was about 20 centimeters. I mean, but those women had symptoms, obviously. So on a routine pelvic exam, I have found fibroids before that were probably about 5, maybe 3, 4, or 5 centimeters, but not always, no. But that is one of the things we're looking for on a pelvic exam. Was that the only question? Okay. Thank you guys for watching the chat. I cannot multitask like that anymore.
Yeah, no, there's a lot of questions, and they're all really, really good, but let's just keep going and we'll go through all of them.
Okay. Let's talk about hysterectomy. So sometimes hysterectomies, so what is a hysterectomy? A hysterectomy is typically taking out the uterus. Oftentimes we also take out the fallopian tubes with the uterus, because without the uterus, the fallopian tubes are pretty useless. And also they can become cancerous later. They don't do anything other than transport the egg to the uterus. So with no uterus, let's take out the fallopian tubes and remove that as a potential for cancer. Sometimes we take out the cervix, and sometimes we don't, and that gets real complicated. And so, but in general, it's at least the uterus and the fallopian tubes, if not the cervix. Sometimes we take out the ovaries, but that's typically in an older woman who's already undergone menopause. There are other reasons to take out ovaries, but I just want you guys to know that that's not typical. That's not the standard in a younger woman who has not undergone menopause. Sometimes we don't take them out with women who have undergone menopause. But again, that's a whole big conversation. Okay. So there are different ways to take out the uterus and the fallopian tubes. Sometimes it's a big incision in the abdomen. It's called an exploratory laparotomy. Sometimes it's little incisions or laparoscopic surgeries. Sometimes it's just one little incision if they're using a robot. Sometimes it's done completely through the vagina with no other incisions. And what type of surgery you would be getting depends on a lot of different things. How big is the uterus? Why are we taking it out in the first place? You know, like, is it huge? Because if it's huge, not going to get it out of the vagina. You know, what other surgeries have you had? You know, because other surgeries, and in my spina bifida population, specifically things like bladder augment, you know, do cause a lot of scar tissue. And that's not something we can do through the vagina. And a lot of times we can't do it laparoscopically either. You know, we have to really be able to see and carefully dissect, you know, and a lot of times we'd have to have urology with us, you know, like, because we, you know, if we cut the wrong thing, we could be hurting you know, and so we might need them there, again, depending on your surgical history. Would a hysterectomy cause scar tissue itself? Yes, it will. You know, like how bad, what am I doing? You know, like how bad is the scar tissue? Depends on the patient. You know, will it ever cause problems? Depends on the patient. Sometimes we can't predict that. About triggering menopause. So if we take out the ovaries and you haven't undergone menopause, yes, ma'am, it will. Okay. Typically, if we only take out one ovary, it won't necessarily trigger menopause because Mother Nature is amazing. And typically, once you just get one ovary out, the other one just takes over. You know, like even people who have one ovary out can get pregnant at a very similar rate to people who have both ovaries because Mother Nature is amazing. And if you do, but there are some times that that does happen. And so if you do get into menopause, are you eligible for medications that might help with those issues that can happen, like hot flashes and things like that? Those things are important. And then especially in my spina bifida population, how is this going to affect my pelvic floor? You know, like, can they even predict that? You know, what type of changes can we expect? Are you going to feel different, or is your partner going to feel something different during intercourse? You know, like maybe for the better, maybe for the worse, you know, like it depends. And so these are all questions that you should have, and many, many more, quite honestly, like about post-op recovery and things like that, that you need to have answered to your satisfaction before undergoing a major surgery such as a hysterectomy. Another question is, can my problem be solved without a hysterectomy? You know, like, because if your problem can be fixed without a hysterectomy, girl, you don't need a hysterectomy, okay? But you're talking to somebody that's minimally invasive, and I'm a big fan of if it ain't broke, don't fix it. You know, any things about hysterectomy before we move on?
Yeah, I just wanted to point out that being older, I had a hysterectomy, like, I don't know, going on 15 years ago. And they, you know, basically told me, hey, you have to have this. And I didn't ask a lot of questions. A lot of things weren't brought up other than, you know, the surgeon saying, hey, this is going to fix your problems. You know, having had 3 cesarean sections already, I had to have the abdominal surgery. And, you know, here I am all these years later having to have PT for something that's not really a whole lot of fun. And, you know, the PT is telling me that, hey, you know, had they talked to you about this when you had the surgery, that maybe they could have avoided, you know, some of the scar tissue, or maybe they could have, you know, helped you with some of these other issues. Now, I don't know if that's completely true, but I think, you know, it's kind of one of those questions of, had I known then what I know now, maybe I would have made different decisions. But, you know, you can't always look back and say that. But I do think it's important that the younger population, before they go through a lot of these surgeries, which seems to be in the spina bifida category all the time, is there's always some kind of surgery we need to have, you know, ask all the questions. I mean, seriously, ask as many questions as you want till you get happy answers. So that's just my concerns with hysterectomy with a spina bifida patient. And then, you know, now all the other issues that have crept up along the way as we age. And I think some of that is just because the gynecologists, the obstetricians, they didn't have anything to go by. There's no book on, hey, this is how a spina bifida woman will age. So I don't know. I just really wanted the younger people coming up to really ask and ask and ask.
Absolutely, 100%. Everyone you should have all of your questions. And I think this is a good time for you to ask your friends about, you know, what questions would they ask, you know, other patients that you may know, you know, what do you wish you had asked, you know, using your networks, bringing your family, you know, like They, you know, even with COVID restrictions, guys, we've got telemedicine visits. If it's just a discussion, you don't have to go into the hospital. You can have people with you, you know, making sure that you're getting your questions answered. If there is any time at all that I want my patient to be demanding, it's before I operate on them. Yeah, like I want them to have, I don't ever want to operate on a patient that's only half on board. You know, like I don't want that either. You know, like as a surgeon. And so I want my patients to be ready, prepped, and feel committed to what they want and that this is what they want. And you're right, there aren't books on this. And so we can't always predict what's going to happen in the future, but at least if you feel like you've got your information and the best information that was available at the time, then it at least removes some doubt from you later, you know, that you did the very best you could at the time, you know, that you didn't have an unasked question. Does that make sense?
Yeah, completely. Thank you.
Sure. Sexual stuff. Let's talk about this. You know, like, so whenever we're talking about sexual concerns, and I do encourage you guys, and I encourage everybody.
Can I ask a question, please?
Yes, please.
Yeah, I had a bladder cancer in 2012. There was a dance, and they did a complete hysterectomy. And they said that was a usual thing that they do. Is that correct?
I don't know the answer exactly. So it may be yes, that in that particular situation, yes. Bladder cancer is a little out of my realm of expertise. So it may very well have been yes. Like if it was invading the uterus, or if in order to remove the tumor, they had to dig into the uterus too much, yeah, that may have had to happen because they're right next to each other. And so when something affects the bladder, it absolutely can affect the uterus and vice versa.
And we're having, oh, I'm so sorry. There was a response to a chat, and I actually, Courtney, were you responding to the question in the chat? Courtney Store is a urologist, and so
Sorry,
she was asking, yes.
sorry. I was just trying to say, can you hear me?
Yes.
It is standard of care when you have bladder cancer to remove the uterus because it often invades. There's some, like just now they're doing some investigations, and like in some very limited cases, maybe they'll leave the uterus, but it's standard of care, and that's to prevent cancer from spreading in there.
I'm so happy we have a urologist. Thank you. Okay, sexual stuff. So things that people often have questions about are things like bladder and bowel incontinence and how to manage that. Positioning can be a concern, or mobility. You know, there's always a concern about risk of fractures, whether or not somebody's going to have a sexual response, and need for use of lubricants. You know, so here's the thing, guys. All women have these things. You know, like that's the thing that I think is revolutionary to some of my patients is they think they're coming to me and they're asking about how to avoid, you know, accidents like bladder incontinence and bowel incontinence, so they're afraid. And I'm like, madam, do you know that the towel is universal? Like it's something that all women experience, you know, like, you know, bladder leakage is not isolated to spina bifida. You know, like that's something that happens to a lot of women as they grow up, you know, as they get older. After they've had multiple kids and things like that, it happens, you know, like it's so amazing because it's so common. Bladder incontinence is so common, and yet it's like this thing that no one ever talks about. You know, when patients tell me in my general gynecology clinic, and they say, and I say, any problems? And they're like, I think I might leak a little. And I'm like, yeah, that happens and they're just amazed. So it's not just spina bifida patients. Everybody has to worry about positioning, guys. Okay, like everybody has, people need lubricant. Okay, it's not just y'all. You know, some women will not have the same sexual responses as others. You know, like this is all very standard. So please, please do not feel some type of way about asking about these things or bringing these things up, because your gynecologist is having to answer questions like this all the time. You know, like this is life. You know,
I do have,
yes, please.
I do have a quick question. So I have only taken one semester in college of anatomy and physiology. I remember vaguely someone saying that the nerves to orgasm and the nerves to go to the bathroom are either connected or very close together. And so sometimes that can be the cause of accidents and things like that. Is that true, or is that something that I'm just making up in my? I
actually, and maybe our urologist remembers, I don't remember exactly what the nerve endings are that do both, but yes, it's very common, you know, like to have at the time of orgasm, or even just with the act of having the penis in the vagina, like going up against the bladder, leaking. Yeah, like it happens all the time. Yeah,
The first time you talked about this, Dr. Harris, I know it wasn't my first time hearing it, was through you maybe a week ago. And I wish they'd recorded my reaction, because it was like, what? I'm in my late 30s and finally someone has told me that this is what all women experience, not just women with spina bifida. So that was really cool and pretty funny.
You know, and I see that all the time. And it's a shame. You know, like, as I'm glad that you got the information. I am just horrified that it took that long. You know, like, we need to start, I think, we need to start talking about these things early with patients, and particularly spina bifida patients, because we know that standardly they will have, you know, some of this, but we need to normalize it, because it is normal. You know, it's all normal. You know, like, and so I think people think it's abnormal, and it's not. You know, like, and I think they get afraid to ask or embarrassed to ask. And yeah, please don't be embarrassed with your gynecologist. Y'all, you are not going to say anything to shock us. Okay, like, we have heard it and a lot more. Okay, I promise. It takes a lot to shock a gynecologist. Okay. Okay. All right. I know you guys know who are on the panel that I could talk about this stuff for like an hour. So I'm going to force myself to move on. Prenatal stuff, obstetric stuff, counseling. So can you get pregnant? Yes. You know, like, there's nothing about spina bifida that makes it so that you can't get pregnant. Okay. Now, can everybody get pregnant? No, because not everybody can get pregnant. You know, like, there are reasons that happen. I'm not just talking about spina bifida. Infertility can be a problem for anybody. You know, and so, but there's nothing about spina bifida that makes it so that you can't get pregnant. You know, like, I don't know why that's not clear. Like I don't know why people haven't made that clear, because people seem to be shocked sometimes when I tell them that. And I'm like, no, you can get pregnant. Please don't use that as contraception. Yeah, like this idea that you can't. So if you're interested in getting pregnant, please let your doctor know, because there are some things. So is spina bifida pregnancies, are they going to be a little bit more complicated? Probably. Yeah, like, for most women, it can be a little more complicated to a lot more complicated. And so I think every woman should know what they're potentially getting into, you know, like, and plans can be made, you know, and so definitely let them know. Or even if you're not sure if you want to get pregnant, hey, it's never too early to talk to somebody who specializes in this. You know, like, for some women with spina bifida, we have to have a lot of consultations. You know, like we might need to talk to urology. We might need to talk to neurosurgery if you have a shunt. You know, like there's things, or we may not need to do any of that. You know, like it depends on the patient, just like in everything else. It depends on the patient. So talk to them. At the very least, we do recommend folic acid at 4 milligrams daily, ideally at least 3 months prior to pregnancy, and continued until at least your 12 weeks gestation. That's to prevent open neural tube defects, you know, like if we can. And so you guys, everybody, every woman of childbearing age who engages in reproductive type sex should be on prenatal vitamins. It's just that the standard dosage for somebody without a history of spina bifida, either themselves or their family, is less than patients who have them. That's it. You know, like not any different. Talking about delivery. So again, this is all about things that you should know before you get into it. Okay, like the things that I wish I had known before I had a child. You know, like I knew the obstetric stuff. I don't know that I knew much about having a kid. You know, like, but you know, we should all be informed about these things before we get into it. What kind of sensations could you feel? You know, what should you not be feeling? What anesthetics are available to you? Are you a candidate for things like an epidural? You may or may not be. You know, like, and it also, you know, what about spinal anesthesia? Like, do you have, if you need a C-section for whatever reason, do you have to be put to sleep or not? You know, like, what about other types of blocks? You know, like what's available to you? And then also, can you even, like, what kind of positioning can you be in? You know, like, what are the risks of those positioning? You know, like, can you push? Can you not? You know, like, this is all very dependent on the patient. But these are all things that we think about in advance.
Kara, we have a question. What if a woman has a shunt? What concerns should there be?
About pregnancy?
I was just going to ask, Lena, was the concern about pregnancy specifically, or delivery?
Said yes.
Oh, yeah, yes, both pregnancy and delivery. Like, is there more precautions, or?
It's not necessarily more precautions. It depends on the other surgical stuff and the other things going on. I will say that when women have shunts, they, in my experience, also tend to have had other surgeries that we tend to, so when women, okay, more, let's talk about a general population, not just spina bifida. When women have had multiple surgeries for whatever reason, be it multiple C-sections or bladder augments or bowel stuff or shunts or whatever, you know, like, again, with the scar tissue, okay? So all that stuff kind of moves stuff around and makes scar tissue. Scar tissue in a regular surgery can be challenging to deal with because you don't want to get into something that, you know, and hurt it, you know, because it doesn't look the way that it normally does, and things don't necessarily live where they normally do. Mm-hmm. In a delivery situation, so for anybody who's pregnant that's delivering a baby, anybody could require a C-section. And a lot of times it's because the baby isn't liking labor. And sometimes babies really don't like labor. And we have to go very, very fast. So with women who have multiple surgeries or other considerations, we can't do it fast. You know, like, or we can, but I mean, we may really regret it, you know, like, because we could really mess some stuff up, you know, and so that is one of the reasons why a lot of women with spina bifida don't have to necessarily have a C-section, but some women with spina bifida need a C-section, and some women with spina bifida who maybe could potentially have a vaginal delivery, but you know, we have to think about that emergency, like what happens? Are we willing to take the risk to the baby's brain if we can't do this quickly? You know, like that, that may be an encouraged C-section. And so that's what I would say. I don't know specific, so I have not yet had a patient with spina bifida and a shunt in a C-section. So I don't know exactly what neurosurgery would do. The only patient that I've had that had a shunt actually just ended up coming in and delivering the baby. You know, like the baby just came out. You know, like, so we didn't even get to the OR. You know, like, so her shunt was fine. You know, like.
Yeah, because it seems I'm a nurse in a pediatric clinic in Lansing, and it seems like some of the women that I know, they don't have shunts. It just happens to be that have had children. So, you know, I have some teenagers and stuff moving on that, you know, what do I tell them? So, yeah.
Tell them that it's that they absolutely can get pregnant and that they can absolutely have a healthy pregnancy. You know, like there's nothing about their spina bifida that means that they're doomed to not have a healthy pregnancy.
Right, right.
And that are there considerations? Yes. You know, like, will all women with spina bifida have a healthy pregnancy? No, because not all women have healthy pregnancies. Yeah. But that they need to start identifying an adult OBGYN who can, you know, start that ball early about what can they expect and talking to the people and getting that stuff, you know, getting that ball rolling. Because again, it's about planning. You know, like that's what it's about. You know, it's about planning. Yep. No one should have an unintended pregnancy, period. You know, like, and so the more planning we've got, the better.
We have another question, and you know, we really appreciate everybody staying on because this is really great. So in the case of this woman, both she and her husband have spina bifida, and they tried getting pregnant a few years ago, but were not able to. In an earlier message, also mentioned that there were some, you know, a lot of fibroids as well. But she says that both of them does the fact that both of them have spina bifida, is that what made them not be able to get pregnant? Could it be genetics?
Not necessarily. So there is a higher risk of having a baby with spina bifida, with both parents have spina bifida. It's still not most of them, you know, particularly if we put in the folic acid, but there is a higher risk. So it's hard for me to comment without knowing more about someone's specific obstetric history. Like, was it I mean, I'm sorry to bring up painful topics, you know, like, but it's very individualized. But I will not, I can't say that there's it's just because both parents had spina bifida. Does that make sense? Like, there's other things. So I'd have to know the full story. And that gets very personal.
Right, and then would it be accurate to say then as well that, you know, maybe, you know, if you haven't already, seeing a genetic counselor, maybe there's like a refer to a genetic counselor that might be able to provide some additional insight.
Absolutely. That's so when I have a patient, I refer them to genetics, to maternal fetal medicine, and then urology, neurosurgery. I mean, often they have these people already. And so it's just, hey, by the way, did you know she's thinking about getting pregnant? You know, like in advance, you know, like can talk to her about what that's like, you know, like, so yeah, that should absolutely be one of the standard referrals is a genetic counselor.
And then once you do get pregnant, the MFM essentially takes over your care from there because you'd be considered high risk?
Most of the time.
Most of the time,
so
yeah.
There's some, well, it depends on what facility you're at. At our facility, MFM does have their own service and their own patients that they deliver. That's not true everywhere. Sometimes they're just a consultant, And so they just basically kind of direct the care, but the person who you went to originally is the one who's actually providing the care. And again, just like everything else, I have kept some of my own spina bifida patients for me to take care of. Again, this is all dependent on the level of the lesion and what I felt comfortable with versus what they needed to do. And so the ones that I've had, I did get their input, but ultimately I kept them because I knew I could manage this. And my partners, it's not even just about me, it's about my partners, could also do this. Whereas patients who needed more complex care, I needed to send to MFM because I do not have the pull to call neurosurgery in the middle of the night, like they do. So. Okay, I'm gonna keep going and quickly. Okay, contraception. Okay, so let's say you're not trying to get pregnant. Okay, let's use some contraception. So there are lots of different hormonal and non-hormonal options. You do have, so some women with spina bifida, specifically the non-ambulatory patients with spina bifida, are at a higher risk of blood clots in the legs or lungs than a general population. Some of them more than others. Okay, so not being totally ambulatory is not in fact a direct contraindication to any type of hormonal management, and I want to make that clear. You can be, the thing that we worry about typically is estrogen, because estrogen can help create blood clots. And so that's what everybody gets freaked out about is, well, you already have one risk factor, so are you going to get another one? And is this going to be the thing? But it's not a contraindication. And so there are plenty of patients that have spina bifida that are on estrogen-based contraception, and they are fine, okay? But it's individual, just like everything else, because there are lots of other contraindications that people may have, that mean that they can't get estrogen safely. We use hormonal medications for more than just contraception. We use it to manage cycles. Some people have a lot of bleeding. Some people have a lot of pain. Some people have bad PMS symptoms or menstrual migraines. Some people just have issues with hygiene because of their differences. Like it's hard to clean up sometimes. Some women actually have worse or only have seizures with their cycles. So there's lots of reasons why we use hormonal contraception that's not just for contraception. Plenty of women who are not sexually active or not having procreative sex end up needing this stuff. So hormonal contraception will either have estrogen and progesterone or only progesterone. Like I said, lots of contraindications to estrogen, hypertension, migraines with aura. If you've ever had a history of a blood clot, if you have a seizure disorder, it's not that you can't have estrogen, but there are other considerations that we have to take into account that make estrogen therapy a little bit more complicated. And this is just a short list. There's a ton more. There's not as many contraindications to progesterone, only a very few actually. So that's something that might come up.
So Tara, which contraceptive methods, hormonal, which ones are more likely for blood clots? So like me, myself, I don't mind sharing, I'm on the shot. I think it's progesterone, I think is what it's called.
It's medroxyprogesterone.
Okay.
So that's only progesterone. And so there's not estrogen in it. So there's not that additional risk of blood clots that happen with estrogen. Like I said, there's very few patients that have concerns with progesterone. So.
Okay, thank you.
No problem. And we're gonna, and I'm gonna go through some of this quickly. Okay, since I've taken so long, I'm so sorry. Contraception, just like any other medication, contraception can have side effects. Like I said, with estrogen, you could have an increase. It's a small increase of risk of blood clots or stroke or heart attack. It's small, but it is there, and for some people that small risk is a big risk. And for some people it's like, well, not so much. There is an increased association with breast cancer that is actually with any hormonal method, not just estrogen. Association is not causality. We don't understand exactly what that is. And certainly it's not a large enough association for us to say, oh no, take this off the market, but it's there. Of course, there's also a decreased risk of ovarian and uterine cancer. So as I like to tell people, pick your poison, so there's risk and benefits. Okay, going through some stuff quickly. So there's the birth control pill. You may have either, can you guys see my cursor? Like, you seeing this? Okay. So these are
yes.
typical ones that have both estrogen and progesterone. And then you have ones that are progesterone only, which the word is norethindrone. Okay. So you won't see progesterone on that pill pack, you'll see norethindrone. And so these are very good. And so they're not perfect because nothing is perfect, but they are very good. You do have to take them every day. Typically the issue that we have with failure for contraceptive purposes is people forgetting to take them. This is very often used for things like menstrual control. All of these things can be used for that, but a lot of times when people come in with a lot of pain with their periods or heavy periods, the go-to is really the birth control pill, y'all. So that's what they look like. There's a patch, which also has both estrogen and progesterone in it. Same types of medications, same types of effects, just a different delivery method. This is helpful sometimes for people who forget to take pills, and again, it's very good, not perfect. This is a picture of the Nuva ring, which is a vaginal ring. It has both estrogen and progesterone in it. How you use this is the patient pinches it just like this and puts it in the vaginal canal. It doesn't go into the uterus. It doesn't go past the cervix. It sits in the vagina. And it stays there for 3 weeks, and then you take it out, and that's when you get your period for a week, and then you put a new one back in. And again, very good. I did check, neither the Nuva ring nor the patch have latex. Important for you guys to know. This is the shot. We all call it the shot. It's great. It's Depo-Provera, or but we all call it the shot. I have the shot. And this is just progesterone. This is given once, typically every 13 weeks, but sometimes that dosing is a little bit different depending on the patient. But typically it's given once every 13 weeks. Just like the other things I've just done so far, it's about 96% effective in preventing pregnancy. And it's also used definitely for menstrual suppression. This is a picture of the Nexplanon, or what used to be called the Implanon. So it's a little plastic rod, not latex, that we insert right under the skin. Because you can't forget it, it gives off a little bit of progesterone all the time. Because you can't forget it, because it's under the skin giving it off, it's actually a very effective method of contraception. So it's 99.6% effective for birth control. That's really good, and so it's a great option. It also doesn't hurt when I put it in, I promise. And then here are some IUDs. Sorry, I'm talking. So there's there's two general classes of IUDs on the market, or intrauterine devices. These are little devices that we insert into the uterus. So there is the hormonal, which has progesterone only, and then there's the non-hormonal that has the copper. I'm only aware of one copper IUD. It's called the Paragard. There are several progesterone IUDs on the market. Some of them are different size, and they last for differing amounts of time. They have differing amounts of progesterone. It just like the Nexplanon, it's excellent for birth control. Now, a caveat with this is, with the IUD, there are some patients with spina bifida that aren't good candidates for the IUD. And it has to do with things like prolapse and recurrence of infections and levels of lesions and things like that. It's highly individualized. I would never say, oh, you have spina bifida, so you can't get an IUD. But there are different considerations that we need to take. And so this may or may, just like everything else, this may or may not be a good option for a particular person. But there is that special consideration with patients who have prolapse versus the other stuff. Non-hormonal methods, well, we just talked about the copper IUD. There are condoms. There's male condoms. This is a male condom. This is a female condom. There are most condoms that we talk about are latex. There are non-latex condoms. Condoms are the only way to protect against STDs. So pregnancy isn't the only problem here, folks. You know, like you got to protect against STDs. STDs, some of them, yeah, we can clear up really quickly with like an antibiotic, but some of it can actually cause cancer and kill you. You know, like, so we got to be careful. Okay, like, so if you're not trying to get pregnant, there's literally no reason you can't use a condom. Okay, like even if it's a non-latex. Are the non-latex ones slightly less effective? Yes, but that doesn't mean you shouldn't use them. Okay, like, but they may not, but if you investigate it, they may not be, just like condoms in general, you may not be comfortable with the failure rates if you're trying to not get pregnant. You may want additional contraception, you know, like, so there's that, but you should still be using them. Talked about female condoms in the first picture. The sponge is a non-hormonal method that I used to be pretty big in the 50s and, well, really the 60s and 70s. It's this little sponge thing that a woman puts inside her vagina to try to block, it's a barrier method, to try to block the semen from getting into the cervix. It's a lot like diaphragms and cervical caps. But also like diaphragms and cervical caps, the effectiveness isn't there. And so they've really fallen out of favor. Diaphragms and cervical caps have to be fitted by a gynecologist. Here's the thing, guys. I started in a couple years ago. I'm not going to say when. And I have never seen a diaphragm or a cervical cap, nor do I have any idea how to fit one. You know, like, so it's really fallen out of favor. The sponges, you can order off Amazon. I believe they have to come from Canada. You know, like, so look, guys, it's better than nothing. Okay, like if you're trying not to get pregnant and you can't do X, Y, and Z hormonally, and this is what you got, and this is what you got. Okay, order them. And they come out after intercourse. Spermicide, again, it's going to help it's going to help you keep getting pregnant, or it's to keep you from getting pregnant. It's got a high failure rate, but you know what? Just add it on in. You know, like, now there are some people who have some allergies or some reactions to certain spermicides. So you know how they always tell you with new products to do a patch test? Y'all do a patch test, okay? Like, so if it irritates you on your hand or your arm, don't put it in your vagina. Just a good rule of thumb. Okay. And then there's sterilization, which is permanent, okay? So there are different ways of sterilization. There's actually now the typical thing that we try to do is actually, you know, I said with hysterectomy, we take out the tubes. We try to take out the tubes where we can, because it decreases your cancer risk. But you can't get them banded or clipped or removed. E-Sure has been banned in the United States. So I need to take that off because we don't do that anymore. But it's real good, but it is permanent. And then there's the withdrawal method, which for those of you who may not be familiar, is when you have penis in vagina and you get almost to the point of male orgasm and then he withdraws. As you can imagine, it doesn't work that way. But it's better than nothing. So, and then there's fertility awareness methods or natural family planning, which can be pretty effective, if not highly effective, about counting, trying to avoid your days where you could get pregnant. But you do have to have reliable cycles. If you don't have reliable cycles, this isn't going to work well. So just so you know. Okay. Woo, that's all I have.
That was awesome. Yay. Thank you so much for Tara. Thank you so much.
Dr. Harris, we do have one question that would just pertain to something you just said. Talking a little bit about how contraceptives help people with recurrent ovarian cysts. Someone was put on the pill at age, when they were a teenager, after having an ovary removed due to recurrent ovarian cysts. Can you talk a little bit about that?
Yes. So it was the birth control pill, right?
Yes.
Yeah. Okay. So ovarian cysts. There's lots of different things that cause ovarian cysts. Okay. Something that people may not be aware of is every month that you ovulate, you create a cyst. Okay. It's part of the natural cycle. Okay? If you were to get pregnant, it would become something called the corpus luteum, which would actually produce the hormones to sustain the pregnancy until a certain amount of time. So typically what happens is you ovulate, you create a cyst, it stays around for a little bit and then it regresses, okay? But sometimes they hang around for a long time. And sometimes they don't regress, they get bigger, and so if you stop, so these are ovulatory cysts, okay? Different than something like cancer, okay? But these types of cysts can recur if you're just somebody who that just keeps happening. They can get bigger, they can hang around, they can cause a lot of problems. If we stop ovulation, then we stop those cysts from forming in the first place. So that's how the birth control pill can actually help with cysts. So I hope that answers that.
So thank
Dr.
you
Harris,
so much. Oh, I'm so sorry. I just want to say, I want to jump in quickly because we are super way out of time. We're like an hour and 40 minutes in. And so I just want to be respectful of everybody and, Dr. Harris and the presenters. So just, Dr. Harris, are you willing to take another question?
I am.
Okay. All right. Very good. Thank you.
Sure. What's the question?
Go ahead.
So Dr. Harris, I had a quick question. So I was told that I had pelvic congestion. Is that something to be worried about or concerned about?
Not necessarily.
Okay.
And so, so pelvic congestion syndrome is a little bit of a controversial topic in my job. And so it can, there are some people who believe that it can cause significant pain. It's not dangerous, if that is helpful information. Sometimes people just want to hear this is dangerous or this is not dangerous. It's not dangerous. There are some people who have it that it doesn't cause any problems. And that's fine, because it's mostly a radiographic diagnosis. And so sometimes you'll get an ultrasound and it'll say evidence of pelvic congestion syndrome. You're like, what is that? Yeah. But if you're not having pain, then who cares? And so, so this is how controversial it was. When I was a resident, it wasn't that long ago, but when I was a resident, there were many of my attendings who thought it was something completely made up. It was like, no, that's not a thing. That's a theory. And now we're starting to think, well, maybe it is a thing, but it's not anything dangerous.
What is it?
Go ahead. Sorry.
What is it? What is?
It has to do with vasculature in the pelvis kind of building up and not draining well.
Gotcha. Okay. Because to me, I think congestion here. And I know that's probably not what's going on down there.
No.
Not exactly. But it's like the vessels get congested.
Okay.
Okay.
Thank you, everybody, for all your questions. And Angelo, I totally see your questions, and I'm going to jot them down so we can address them for sure later on. And I don't know, we might just need to do another one of these, because this was an awesome opportunity to, I mean, it really, so many of us have all the, a lot of questions, and this is great. So we are so appreciative, Dr. Harris, for your time.
Oh no, I love it. Thank you so much. Asian education is actually my favorite thing. Like if you can't tell, like with how I start off with anatomy and what's a period, like answering questions is, like I said, I have the luxury of being supported. Like I don't have to worry about getting patients in and out, and so this is fun for me.
Great.
Thank
you so much. Yay! Oh no, this was great, and we'll have you again for sure. Awesome.
So
Thank you so much to Libby and Sammy and Karen and Kristen and Amy and Judy, and thank you so much for our special guest appearances of Lena and Courtney. It was really good to see you guys. So thank you so much, everybody, and have a good evening, and we will be in touch.
thanks, guys.
Thank you.
Bye, guys.
Bye.